Take it away, Jeff.
Good morning. This is Jeff Weinberg, president of Caregiver Champion. And we haven't been doing any Zoom features lately, but I am so happy to be able to introduce to you Dr. Suzanne Labriola. She is a doctor of internal medicine, as well as, and this is her uniqueness, as a board certified physician in palliative medicine. And that is very unique in the field today. I heard Dr. Labriola speak about a month ago at a workshop that we presented through NAPAC, which is the National Association for Aging in Place. And she was just fantastic. The information she provided is so valuable and much needed. And unfortunately, most people get into what she's going to talk about way too late. And I, as a healthcare advocate, have encountered many people who all of a sudden their loved ones in the hospital or they're dying or whatever the case may be, and they don't have the information, they don't understand the information, nor do they have the documents that they need in order to pursue whatever needs to occur for their family member. So with that introduction, I am proud and it's a pleasure to have Dr. Labriola here, and welcome.
Thank you.
Yeah, thanks so much for joining us today. I'd love to start out with just learning a little bit more about your background.
Mm-hmm. Yes, well, I am a Pittsburgher, born and raised.
The Steelers, even though they were close.
Yes, it was a little health scare last night for some of us.
Right.
I trained back in Pittsburgh at Mercy Hospital in internal medicine and started practicing in what's now the AHN system. I was a hospitalist, so took the training of internal medicine, which is a lot of hospital-based rotations, and went right into that role. Worked as a hospitalist for a few years, did a lot of overnight shifts, and I had to respond to patients who had emergencies in the middle of the night, and was running the emergencies on patients time and again that I knew our CPR efforts were not going to help. CPR is intended to keep patients alive who have traumatic injuries, who have a sudden cardiac irregular rhythm. It's not intended to keep our frail patients alive, patients with multiple comorbidities. And so we knew that not only were we not going to be able to help, but patients were picking and choosing parts of CPR. So I also knew that that wasn't going to be effective. And so I moved into the role through training and through board certification of palliative medicine so that I could try to encourage these crucial conversations of what kind of care and where we want our care to be when we might not be able to say it on our own. And then really focusing on the evidence behind what CPR can and cannot do to make better informed decisions for ourselves and for our loved ones.
I love that.
Making informed decisions is so important. I mean, that's what I try to do, is let people know what the alternatives are so that they can make an intelligent decision. And most of the time, that's not available. And for you to be a doctor and presenting this to them is just fantastic. I really respect that.
Thank you.
We need more of that. It's a great introduction. So thank you for that.
Yes.
Were you going to say something?
Just that when I give the information too, I'm not there to change anybody's mind, right? To Jeff's
No.
point, that I want to make sure you have the information so that you're making the decisions. Or
Right.
if you have to make them for your loved one, you're thinking of what they would have wanted us to
Right.
do.
Right.
Yeah. Yeah.
Right. How did you decide to specialize in life-ending decision making? You kind of touched on it at the end there, but
Right. I'm good at having the conversations, and I liked creating those bonds with patients.
mm,
Um, the hospitalist medicine model, we move very quickly. We get our answers quickly. We want our patients to turn around, to get out of the hospital, to not have prolonged stays. So you don't build relationships.
mhm.
And it gave me a chance to, sit down, talk, learn their grandkids' names, their pets' names, where they grew up. And I mean, I'm Italian, I'm a talker. And unless I sit on my hands, it's hard, not to make those connections. And I really love that. And
Hmm.
I love that I can take the time to have conversations, because if we're waiting for that hospital setting to begin the conversation of goals of care, it's a lot longer of a conversation.
Yeah.
Yeah.
And
Yeah.
to interject with that, the average doctor spends about 7 minutes with each patient they have. And I mean, I am just so thrilled to death that you're here because you're such an exceptional, unique physician in the field. I mean,
Yeah.
Thank you.
you're amazing because it's like everything that I philosophically I believe in. So
Yeah.
thank you.
Yeah. I second
Yeah.
that.
And I don't think that it's so much the physicians, right, who want the limited time, right? We've set up a healthcare system that's controlled by insurance, and that
Right.
puts the pressure on physicians. And until you take a step back, and maybe some of us did this during COVID and during our quarantine, to really focus on what's important to you. And unless you have the means to try it, right, to
Right.
go on your own, or to do it differently, a lot of, I would tell you, physicians feel trapped too. Yeah.
Right.
Oh, I don't doubt that. I think a lot of people in the healthcare field do feel that way because
Yeah.
they're caring people.
Right.
Mhm.
Right.
But just a plug for myself, and I don't know when it'll be finished, but I'm writing a book about healthcare called The Emperor Needs New Clothes. And it's all about bottom line money and being run by insurance companies and pharmaceuticals. So again, you're right on with what your perceptions are.
Yeah.
Yeah. And that leads us to the next question. Why do you think so many people don't want to plan for these types of decisions?
Yeah. Yeah. I mean, it's never a comfortable conversation to have, right? And you always think we're going to have more time to have it. And so you don't start. It's a lot like the elephant in the room. We talk about it. But I think this is a great time of year to have this webcast, because we're approaching Thanksgiving. And it's a time when we're sitting down together as a family around a table. And it's a place to start. Now, I think it was really wise. Somebody recommended during our last talk, Jeff, that you start out by saying, "I'm okay. There's nothing wrong, but I'm ready to have this conversation. I want you all to know what
Mhm.
my preferences are about the kind of care and the location of that care. Should I not be able to say it on my own, or should I need support in making those decisions?" So it's not easy. More and more of us are having conversations, at least internally in our families, but then it's bringing it back to the healthcare providers, or
Mhm.
it's putting it into some kind of a context. And, you know, I don't expect the patients to know all the answers and to think of every possibility that could happen. That's not what the intent is. It's more, what are your goals? What's important? What do you value?
Right.
And it changes too. So it's not a one-time conversation, but it's a place to start.
Yeah, absolutely. Absolutely. I myself am in a social work program, so these types of conversations come up a lot in the program, and studies and statistics are showing a lot more people are now talking about this sooner, also because of current circumstances and more of us thinking about that time. Yeah. So, what is the Pulse report? Living will, POA medical, POA financial. Could you share with people who might not be familiar about
Sure. Yes. So once you've had the conversations, it's important to put some of the decisions into writing. So there's two different kinds of ways to document. There's living wills, advanced directives. These are more of the legal terms we hear. And that talks about what future care may look like. So if I had a life-limiting diagnosis, if I had a traumatic accident, if there's a time when I can't speak for myself, you elect the person to make the decisions for you, your surrogate, and you tell them what kind of decisions you'd want to be made for you. So it talks about future care, whereas a POLST form, so it's a physician or a Pennsylvania order for life-sustaining treatment, it impacts health now. It talks about, what do I want in my current condition and state? And it's intended for patients who have life-limiting illnesses or who want to very clearly put their wishes into writing. And so it's two different ways. They can act together. A POLST form does not legally put somebody in control as a healthcare power of attorney. That's what an advanced directive or a living will would do. When we talk, sometimes when I start talking to patients, I'll ask them, do you have a living will? I'll get answers of, oh, the kids know what they want and who gets what and how I want to be buried. So I often pause because we'll plan our death, but not our dying. So that's more of our financial will. That's more of the estate planning. Whereas the living will and the healthcare power of attorney talks about the care and the kind of care you want should you be facing a terminal condition.
Right.
I love that what you just said, that we plan our after death, but we don't about our dying. And my wife thinks I'm crazy, but so do a lot of other people, by the way.
Not me, Jeff.
But I always talk about like how I want to die. Okay.
Right.
And it's not just, take this away or whatever, and it's also talking about planning my funeral. Okay. And I had a very good friend who died at a young age of brain cancer. And he had planned his funeral. And I have to tell you, I mean, what he did, from playing music to people talking, and him having somebody read what he said to people as part of the funeral.
Wow.
I mean, people couldn't move after the service because it was so amazingly, and everybody was crying, and but it was perfect.
Yeah.
I mean,
but that planning the funeral takes so much pressure off of the family that you've left. So giving them the same kind of roadmap of the decisions that you'd want to be made for you medically also provides that relief and that assurance. Okay, I'm doing the right things. I'm making the decisions they would want me to make. So
Yeah.
just as important. Yeah.
Yeah,
Agreed.
absolutely. I've talked to many people who feel,
I mean,
plagued about those decisions.
and
They
that's
question.
said perfectly, because it's exactly right. It takes all the pressure away from anybody else.
Mm-hmm.
Just by the way, I want to have a terrible towel in my coffin.
Yes. Good. We'll put that in the documents.
I have it in my document.
Yeah.
It takes the pressure, as well as, complications that can arise within families, disagreeing about what should be done and things like that. I've heard so many tragic stories about, siblings not talking to each other ever again and things like that. So having the conversation prior helps alleviate a lot of mess.
And choosing wisely, right? Yeah. So if you have multiple people you could pick for to be your surrogate, first of all, you're lucky, right? But you want to choose the person who can speak for you, right? Who can honor your decisions, and so that choice is also very important. And once you do decide, you have to make sure you have a conversation with them so they're not surprised, and so that you've shared and you've talked more about what you want. Right? You don't want a living will and advance directive to sit in a safe deposit box and never be reviewed, never be discussed. It's that ongoing conversation and the trust that can really help make a difference at that time. You're right. It's not when you want people to be disagreeing. It's hard enough.
Yeah.
And people are surprised that when you say that, because, for example, my daughter is my medical power of attorney because she's in the medical field and she knows what I want and she's comfortable with it, where my wife would not be comfortable with that. Now, she's financial power of attorney, and people go, "You split them?" And I go, "Yeah, because this way I know." And I also put in my living will that, my daughter has to discuss it with my wife. She just doesn't do it on her own. But I know that my wife could never make that decision, where my wife, I keep saying my wife, but my daughter can't.
Yeah. Right.
Can people change? Can people change the information and the reports and whatnot later on? And also a follow-up question to that was, what is hospice?
Right. Yes. So yes, you can change advance directive or a living will. You can change the healthcare power of attorney. In Pennsylvania, they have to be witnessed. They don't have to be notarized. So it gives a little more flexibility and freedom too. And that's in Pennsylvania, right? So a lot of the patients that we see may also come from the tri-state area, a little bit different rules in different states, but at least in Pennsylvania. So yeah, that's why I think it's important to review them and to go over the decisions, especially if there's been a change in the family, a death, a divorce, right? Anything that happens, it's a good time to go over those documents. We've added discussions about advanced care planning to annual wellness visits. So, you might think that that's another funny time to start talking about, what are your plans? Should you become sick or should you have an emergency? But it also gets people more engaged in maintaining their health. So I think that it makes sense to put them together. So it's another reminder every year of, okay, what do I have to do this year? What am I looking forward to? What do I want to review? So it's a good time to do that. And then in talking about what hospice medicine is, hospice medicine is a very particular kind of palliative medicine. So not all of hospice is palliative medicine, right? Palliative medicine encompasses a lot more. Hospice is when the patient is no longer seeking life-prolonging treatments. So not going back to the hospital, not wanting advanced medications or surgeries or procedures, and they're focusing more on comfort and on the quality of the life that they have in front of them, and being comfortable during it. So that is hospice medicine. Hospice is also a change in the way that insurance supports the patient and the family, because instead of paying for admissions to the hospital, costly medications, surgeries, medical procedures, they're paying to help keep patients comfortable where they are. So they'll pay for additional nursing care, nursing support, the medications for comfort, a hospital bed, right? So a lot more goes into keeping the patients comfortable where they are. The hospice benefit, and this is again going to be a surprise to some people, it's at least for 6 months. But in the United States, patients tend to receive hospice benefits for an average of 5 to 7 days.
Yeah.
So very late.
Yeah.
Well, that's the problem. It's very late.
Yeah.
Right. And I know that sometimes it's hard because we might not know when is the last heart failure exacerbation, right? When's the last time you're going to get short of breath because there's fluid in your lungs? When's the last time you'll be short of breath because of your COPD or your lung disease, right? Those are hard. We're not always sure. And every time you're admitted to the hospital, patients never quite get back to their baseline. So when you start to see that decline, we're already probably too late. Cancer diagnoses are also very difficult to take and to know what path you're on, but they are much more sudden in the change that we see. That leads to, I would say, the later use of hospice, but it's also because we're not having conversations at the time of diagnosis of serious disease or critical illness, so that we're not together moving in that space with patients and physicians and families, and we're not talking about it throughout the process.
Yeah.
But to me, so palliative medicine should come at any point when there's a life limiting or a chronic condition or a new diagnosis. Because even in breast cancer, I mean, we have made amazing strides in curing breast cancer, not even treating breast cancer, right? But if you have nausea, and you're going to get nauseous after your chemo, or you have pain or swelling in your arm or pins and needles feelings, these are all symptoms that palliative medicine providers can help. And I've had patients graduate from palliative medicine, right? When you're cured of your breast cancer, you don't need me, but at least I'm there to help you tolerate chemotherapy, to help you get to radiation therapy, right? So it's a lot earlier in the game. And for anybody who's having symptoms along their journey with their diagnoses.
Yeah.
So I have a quick question about this. So if somebody has breast cancer or any kind of cancer, basically, and they're getting chemo or radiation therapy, they can go on to hospice or
no, that's palliative.
palliative care?
Correct. So palliative medicine is we're consultants who can be involved and part of that team, so that while you're pursuing treatments and life prolonging therapies, there's still somebody there who's helping with the symptoms along the way. So you don't have to wait until you elect hospice to address symptoms, to have goals of care conversations. That's what palliative providers are there for.
That really is a tremendous added value. I mean, I know so many people that are going through radiation or some form of treatment, and they don't have access to someone like you.
And it's also difficult because you're right, there's not enough palliative providers across the country. And a majority of the focus for palliative medicine is in the inpatient space. And so finding a consultant to help in the outpatient space has been challenging. And I think that we're getting further and further upstream. And there's more availability of outpatient palliative providers, and I'm trying to help continue that trend.
Yeah.
Can you do it for someone out of state?
So interestingly enough, right, lessons learned from COVID, yes, telehealth is available. And, you know, we're trying to continue to encourage Medicare and Medicaid to support telehealth so that these services can be available to patients at home and families at home and across state lines. So a little work in the back end as far as do you need the licensing? Can you accept the insurance products right across the state lines? But yes, there are services that are available.
That's terrific.
Yeah. Where can people find you? Where can people get in touch if they need help in this area and interested in your services?
Yes. So I've started a webpage to try to help people land there and direct them. It's Integra Healthcare Solutions. .com, and I'm happy to share it so we can also post it.
Yeah, we'll put that in the comments.
Yeah. Okay. And then my email address is Suzanne at integrahealthcaresolutions.com. So a throwback to my Italian heritage and the idea that it's integrated, right? We want that health and that team to be integrated and to look at that, to look at our patients as a whole person and start talking about what's important, what makes 100%. You tick.
Yeah. Now, does insurance cover your services non-telehealth?
Yes. So it depends on the providers, where they're located, and anybody with palliative medicine and background. I am setting up an office practice that can take insurance. So sometimes providers in the community might be a cash-based provider, but we're setting up insurance so that it can be more accessible to more patients and can be either of our two health systems in the area or the independent insurers as well. So, you know, I thought that's important. I want to be able to help as many patients, caregivers, and families as we can. Yeah.
Does Medicare cover this?
Yes, Medicare does. And Medicare would cover even the discussions with your primary physician. For goals of care. Yes, yes.
So we're running out of time here. I want to say thank you so much. I have really enjoyed this conversation. I think this is such an important conversation for other people to hear. So thanks for sharing this information. What you're doing is extraordinary. I know it's very much in line with Jeff and Caregiver Champion and my own personal views as well. So Jeff, is there anything either of you want to add before we close out here?
No, I am so glad that we interviewed you because just like what you do for people, if I can help publicize it in any way, I want to, because they need to know this information. And I'm still not sure about bringing it up on Thanksgiving dinner when you're asking to pass the turkey. But
please pass the sweet potatoes and how do you want to be buried?
Right.
Your family is around that.
Yeah.
Thank you so much. And I wish you and your family a blessed Thanksgiving, and I hope we can keep working together.
Yes, absolutely. Yes. Thank you so much for having me. And another time of the year that we also talk about it is National Healthcare Decision Day, and that's April 16th, the day after taxes, because You can't avoid death and taxes.
What a fun week.
Did you make that
Right?
up?
No, I mean, it's there.
And you know what? It
Yeah.
doesn't have to be a dreary conversation. It really can be fun. My
No.
mom and I
Right.
went for a walk in the cemetery and had a beautiful conversation about, both of our thoughts on it. And so
Right.
when we're making
Right.
jokes about it, I think it doesn't have to be as heavy as a conversation. We can't
Right.
make light of
Right.
it. And, it's all love in the end.
Yeah. Yes. Well,
Well,
thank you. And I look forward to continuing the conversations and our
thank
work.
you.
Absolutely.
Absolutely. Thanks so much. Have a great day.
Thanks, Susan.